Well, I think the main item is that you can't see it, and what you can't see you don't believe. Now, many patients who have stable angina report, if you ask them, about resting angina as well. And often you have to ask them because their main problem is they can't get up a flight of stairs, and that is really nasty because they cannot live. They are inhibited in their daily activities, and they don't really mind that sometimes at night they have a little bit of chest oppression. So if you ask them, you will find a lot of them have resting angina, and resting angina of course can only be due to two things. One is coronary vasospasm, and the other thing is that they have thrombotic events like 7 times a week, which is quite unlikely. That's a very interesting question, and I don't have the answer to this. Now, when I first met these patients who reported about funny symptoms, resting angina, I thought that must be myocarditis. Why did I think that? Because they said it started 6 weeks ago on Thursday. So you never had that before? No. Now, what can start dramatically, not slowly, but like a switch on a Thursday 6 weeks ago? It can only be something infectious, and you often have the history of 8 weeks before. I had some terrible flu, I went to the dentist, I had a bad tooth, something like that. Seems to trigger it. Now, whether this is myocarditis or whether you have some pre-existing condition being triggered by the inflammation, I really don't know. But there seems to be some connection, and of course when you look at patients with angina and you do a biopsy, you look at the vessels, you often see some low-grade inflammation. So maybe there is a connection, but that's as much as I know. Now, that depends a great deal on where you live, because the traditions and the pathways are different in different countries. Although we pretend that we have a European guideline, doctors in Germany approach the patient totally different than doctors in Great Britain. Now, in Germany, many of these patients are being cathed on the demand of their GP, on their own demand, because they want to know what is going on, because they're afraid. Now, when you cath them, very often you don't find coronary artery disease, and we in my hospital in Stuttgart, we perform acetylcholine testing then and try to provoke spasm. We often elicit spasm, we reproduce the symptoms, and at least we know what the patient has, which is satisfying for the doctor but also for the patient, because he or she knows that she is not a psychiatric case, which some of these patients tend to believe because they had several caths before and they were told they were healthy. So that is for the patient who is on the table anyway. But the patient who comes to your practice and just complains about these things, you have to find out the typical features of resting angina spasm, meaning good exercise capacity but dramatic resting angina. That's usually epicardial spasm. And then you have a mixture of complaints, patients who are short of breath when they climb stairs, but they also have some mild resting angina. This is usually microvascular. So epicardial spasm, you just think it is there and you give the patient a calcium antagonist. You bring him back 2 weeks later, and if he says everything's fine, that was the right diagnosis and the right treatment. Microvascular is a little bit more difficult. You can also try to treat it, but in about 1/3 of patients there is no treatment effect, and then you're in doubt whether the diagnosis was correct. And then you can start, for instance, doing a stress echo. If a stress echo elicits the angina but doesn't show any wall motion abnormalities, microvascular angina is highly likely. And if you're a rich man, you can send the patient to have a PET examination showing the reduction in coronary flow reserve, and that makes the diagnosis.